So, welcome to another edition of the Osteopathic Lyceum podcast. Today, we are joined by Paul Kohlmeier, who is, I believe, is co-owner, correct, for Cup in Canada?
Yeah,
Okay.
myself
Co-owner
and
is
my
correct.
wife. Yeah,
Yes, yourself and your wonderful wife, who is a very nice woman. And she likes cigars, apparently.
she does.
Yeah, well, I mean, I had a cigar when I was in her presence, and she said it was a nice cigar. So that's there we
Yeah.
go. So you are again the co-owner of Cup in Canada. Instead of me really walking through a lot of questions, I'll just give you the opportunity to introduce yourself as you see fit, and we will work from there because there's a very specific topic that I've asked you to talk about, and we'll get there in a moment. So tell us about yourself.
Great. I am a massage therapist first. I've been a massage therapist for I'm 27, 28 years, 20, I guess 28 years now, into practice. So just a little bit of time. I feel like I'm starting to figure things out. I've been a registered acupuncturist and traditional Chinese medicine practitioner as well. So I did that after massage school. And so I bring all of that kind of baggage along with me. So I get to talk about, and I do talk a lot about language when we talk about how are we assessing our people, and is what we're is the logical process by which we base our treatments on true.
Okay.
Because in a lot of cases, I don't think it really is when you're
Okay.
dealing with physiologies that don't conform to Western physiology.
Yes.
So, at least Western scientific physiology.
Mhm.
Let's leave it at that.
Sure.
And I am a little bit of a nerd. Love to read. I love reading primary research.
Yeah.
I want to look at the research that people are producing based on the types of things that I like to treat. So whether that be techniques or whether that be for me, the biggest one is going to be cupping,
Yeah.
but I just wrote a taping course. So I went through, 30 years of taping,
Yeah.
like just to see what's there, what's real.
Okay.
You hear a lot of things in classes, and is that held up by what the research is? It may have been when they started teaching the class, but if no one ever looked,
Mm-hmm.
like, are they still teaching what's real? So I wanted to, as a stepping stone, start with, well, here's some research that I can present during the class so that they do have some legs to stand on. And
Yeah. Yeah.
we can say, they have said this about taping, and it's probably not true. So steer away from that. And like, you can use it, but
Mm-hmm.
because they say,
Yeah.
but it's probably not true,
Yeah.
but it
Yeah.
may provide contextual help to your client,
Okay.
right? Because the healing process is partially contextual.
Yeah. Yeah. Fair enough.
So
The so this is and because you just noted that you've done something with taping and looked at research across about a 30-year span, and you've been in hands-on therapy for close to 30 years,
yeah.
would it be, I got two things. So first, would it be fair to say that when you started, the way that things were communicated as far as training was concerned, and essentially say the amount of evidence that would underpin that, has that improved and caused the story to change, or has the story stayed the same but everybody knows that the evidence doesn't support the story?
I think that the the instructors that I like to talk to, and so the instructors that I am in agreement with, let's
Okay.
just put it that way, when we talk about taping or cupping or whatever, we all tend to agree on what we can teach, what
Mm-hmm.
is historical in
Okay.
nature versus real,
Sure.
in terms of what we can say about our techniques.
Yep.
But there are always a lot of people teaching all sorts of stuff that
Okay.
probably isn't true, but they hold it up because that's what they believe. And,
Well,
beliefs don't have to be based on evidence.
well, that's why it's a belief as a yeah. So it's you could call it faith. So I would suggest that faith is essentially a belief in something that you don't current a belief that something can be in existence that you don't currently have evidence for.
Right.
right? So it's a trust outside of yourself that you can't detect, right? So I think the another thing, and I don't know if you've heard this, there's a phrase that I've taken on. Gentleman's name is Brett Weinstein, and it's literally false, metaphorically true.
Okay, that's
Right.
nice.
So you can
Yeah.
have a story that if you scratch at it and attempt to look at it in terms of what I call shared reality, or the reality that is the same between you and I, but we'll interpret somewhat differently because
Yep.
we're different,
Yes.
but there's something that's the same. If you look at things there, the story is literally false. It doesn't match up. But metaphorically, it's true because it guides appropriate repetitive behavior,
Yeah.
right? So I think that most hands-on professions have a decent amount of that, whereby the story that is shared to teach ends up predicting decent behavior in clinical settings. But if you repeat it, it just doesn't hold up to scrutiny.
Yes.
Yeah. Okay. So, and now, as far as taping is concerned, my general understanding at this point of taping is that its ability to, say, brace or restrict movement is relatively poor. However, as an additional sensory input, it seems to do something positive. Am I kind of in the right space there?
Well, it depends on what taping you're talking about,
Okay.
right? So if we're talking about zinc oxide taping, then we're really talking about restricting movement.
Okay.
So, and we know that that starts to diminish if you tape someone and
Mm-hmm.
then you put them on the field or on the
Mm-hmm.
court or wherever they're
Yeah.
doing their thing.
Uh-huh.
It starts to reverse around 10 minutes in.
Okay.
So you start losing the ability of that brace to
Yep.
function.
Mm-hmm.
And by about 45 minutes, it's gone.
Okay.
You might as well not be wearing it.
Yeah. Yeah.
Now, that shouldn't stop anyone from wearing it because there's also that context, that feeling of support
Mm-hmm.
that,
Mm-hmm.
and there's the um, what are the athlete's idea of
Uh-huh.
how their body works.
Yeah.
If they feel like they're being supported by their medical team,
Yes. Yeah.
then
Yeah.
they will mentally
Yeah.
perform better and
Yes.
perform safer and
Yep.
all of that. So
Yeah. Yeah.
there's that kinesthetic chain, even
Okay.
with the oxide taping.
Yep.
With the kinesio taping, what it seems like is it doesn't help much with performance.
Okay.
It doesn't at all brace you. Like it doesn't
No.
restrict any movement. There's no way an elastic tape can
Yeah.
restrict movement, right?
No.
But it does give you that kinesiological effect of, hey, pay attention. Hey,
Yeah.
pay
Yeah. Yeah. Yeah.
attention. And
It's a
even,
novel stimuli.
well, it is a novel stimuli, but even as a novel stimuli, if you leave it on 3 to 4 days, which is what the
Mm-hmm.
general rule is, it actually continues to be a novel stimuli,
Okay.
which
Yeah.
is
Yeah.
unusual because I
Yep.
don't know about you, but I don't feel the waistband of my pants
Yeah.
3 minutes in,
Yeah. Yeah. Well,
right?
see, it's
So
a question of habituation, right? So
yeah,
why
so
doesn't it habituate?
well, and I think that's because it's an elastic that's external to the body. I
Mhm.
think that depending on your positioning, every time it is relaxed in that the two ends are brought at closer proximity, now it's causing a corrugation to the skin
Yeah.
as it ripples. And
Hmm.
then as it's being tensed, you get an outward stimulation of the skin being
Hmm.
dragged back towards the middle of the
Okay.
tape.
Okay.
So I think that just because it's an application, that kinesiological or that kinesthetic sense
Kinesthetic.
of
Yeah. Yeah.
it kind of continues for quite some time.
Okay. That's
It's
interesting.
surprising to me.
Yeah. 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 Well, because so based on what you've said, the prediction would be because it chronically deforms the skin in a novel way, you would chronically sense it.
And that's what it seems. That's what
Yeah.
it seems to be. There's not a ton of research, obviously, in manual therapy. There's not a lot of research on the nervous system,
Sure.
unfortunately.
That's not easy to
Uh,
do.
what's that?
It's not easy to do. And
No,
yet,
it's not easy to do. So I don't know that we have a ton of research that
Mhm.
says that, but we know that even 3 days out, we're still getting responses from the patient that have to do with the tape.
Mhm. That's interesting. Yeah.
Whereas kind of at that 3 to 4 days, you're depending on what again, what you're doing, the elastic's starting to break down, it's starting to peel off, and
Yeah. Yeah.
you
Yeah.
know, or you just take it off at that
Yeah.
point. So,
Well, it might be itchy and funny.
well, it can be.
Yeah.
Usually, if there's stuff like that going on, it's either too dirty or you've put it on with too much stretch, and it's
Yeah.
creating some irritation to the skin.
Yeah.
So,
Yeah. Right on. Okay. So the thing that I noted when I walked into your class at the Canadian Massage Conference, that was in September, if I remember properly.
yeah,
The time moves. The thing that caught my ear was you were teaching a cupping course and you were talking about choosing whether or not to use a noxious or a non-noxious stimuli. Now, as an osteopathic practitioner, in the orthodoxy of the profession, the concept is to consistently be non-noxious or cause no pain response. Now, I know that pain and noxious are different terms,
yeah,
but the concept, and it's the barrier concept in osteopathy. So easy motion to the left, restricted motion to the right. So the indirect barrier, or the barrier of no restriction, is to the left. The barrier of restriction is to the right. So if I can turn the patient to the right and they give me no response of irritation, so no response of pain, then I can do that, but I have to stay short of pain. Whereas if I do this and they immediately have pain, my job is to now engage what would be called the indirect methodology, where I would make the soft tissue soft. So it's essentially, if you wanted to talk neurologically, you'd suggest that you're consistently trying to minimize or remove afferent stimuli. You're just
sure,
sort of trying to make them almost not notice it. Now, I will completely acquiesce to the reality that there are many osteopathic practitioners who don't necessarily follow that, right?
sure,
That many of them will fling you around a table and whack, smack, and crack you. And they will also poke you in places that make you squirm and tell you to relax, right?
yeah,
That
right,
that that real people exist like that, but the orthodoxy of the profession is to avoid it. So to me,
right.
when I hear a talk track that I have with patients is the primary difference between osteopathy and other health hands-on professions is that osteopathy centrally attempts to not make you say ouch, whereas other professions don't mind if you do. They're not
Yeah,
necessarily trying to, but they don't mind it.
yes.
So this is what that kind of general milieu in my brain is what gives me the curiosity about you using the term noxious and non-noxious. Now, you're using it specifically with cupping, or are you using it broadly as well, depending on methodology?
I actually use it quite broadly.
Awesome.
So use it not only in cupping, you can also use it in all of your soft tissue work, because
Awesome.
to me, cupping is just an extension of soft tissue work.
Yep.
Okay. Like it's
Based
just
on
a
what I
different
know
way to,
about cupping,
yeah,
it's
to do different way to do the same thing, right?
yeah.
Except in cupping, you have the strange ability to create space
Mm-hmm.
because of the suction. You're still
Yep.
pressing because the rim of the cup, equal and opposite forces, push into the skin.
Mm-hmm.
And then where the suction is on the inside of a cup, it's causing the tissue to lift.
Yep.
So you get this ability that you don't have anywhere else.
Yeah.
And that's why I like cupping, because it's such a novel sensory experience.
Mm-hmm. Mm-hmm.
So specifically, where I usually talk about cupping or talk about noxious versus non-noxious treatments are, how do you, as a practitioner, once you've assessed your patient, and let's just use range of motion assessment because this is usually where I introduce the thought.
Mm-hmm.
When you're doing range of motion assessment, you will test the soft tissue, never mind the joint. Let's just ignore the joint for a moment.
Sure.
Test the soft tissue. So you're looking for tightness versus weakness, right?
Sure.
As a massage therapist, if you have a tight muscle, you want to cause the tone to come down.
Yep.
If you have a weak muscle, you want to increase the tone.
Yep.
The generality of that is, if you want to decrease tone,
Mm-hmm.
you treat it very nicely in a
Yep.
non-noxious fashion so that
Yes.
the central nervous system calms down.
Mm-hmm.
So the central nervous system is reassured, I guess, that there is no danger,
Mm-hmm.
and it can decrease the tone.
Yeah.
Okay, because muscle tone is set by the central nervous system.
Yeah.
Um, yes, in a reflex at the
Yeah. Yeah.
spinal cord most of the time,
Yeah. Yeah.
or locally, but it is set neurologically. It's not
Yep.
set by the muscle.
No, I think the way that I would generally say it is that you have some interplay at varying levels, depending on exactly where you're talking about or where maybe you find the problem, which really, from the external environment of observation, we're not really going to find the exact
No,
thing. We're
no,
gonna we're gonna do really good big stuff, but you have you have a sensory input and a motor output, and you have
yeah,
multiple layers of that, and that in aggregate is muscle tone.
right.
Yeah,
So, but for me, the biggest driver of muscle tone is going to be based around the nervous system.
sure. Yeah,
Okay.
absolutely, absolutely.
So that's where I come from. That's
Yeah.
my point of view.
Hmm.
So, however, if we're trying to do a treatment that increases tone,
Yeah.
we have to make the central nervous system a little nervous.
Yep.
And we do this every day by doing our squats and our things at the gym and, buffing the jacks and doing deadlifts and all of that stuff,
Yeah.
which don't feel good. Like, this is my definition. This is my definition of a noxious sensory input.
Okay.
Okay.
Yeah.
I am going to strain the milk lifting this stupid piece of iron.
Yeah. Yeah.
Okay.
Yeah.
So, why do you listen to aggressive music? Like, everything you do around it is to make you
Hmm.
tighter or more stressed.
Sure.
Right.
Yeah.
You
Yeah.
can be a relaxed lifter. I totally get that. But
I am.
in the realm of the nervous system,
Hmm.
we are applying a noxious sensory input
Yeah.
in order to increase tone.
Hmm.
I lift weights all the time. I don't hurt myself doing it. It's not
Yeah.
about pain,
No. No. No.
it's about noxious.
Yeah.
And so, as a massage therapist, what do I need to do with soft tissue to
Hmm.
make muscle increase tone?
Hmm.
Well, I can do a lot of things, but more than often, you stick your fingers into their tissue
Hmm.
and then you move it quickly
Yeah. Yeah.
or aggressively or abruptly for a really short period of time.
Yeah.
With cupping, use too much suction. And I say too much for
Yeah.
that it won't be non-noxious.
Yes.
All you have to do is overcome that threshold. Aubrey Gowing, who I just had on a conference, and he talks about the threshold he likes to hold is 4 out of 10.
Okay.
Anything below 4 out of 10, you're going to decrease tone.
Sure.
It's calming to the central nervous system.
Mhm.
But as soon as you reach kind of that 4, people start twitching.
Yeah.
They start tensing. And
Uh-huh.
if you're at 5, they're visibly showing you, like,
Okay.
it's obvious that
Okay.
you're in a noxious kind of sensory input.
Sure.
The body perceives that as, hey, there's some danger here and I need
Yeah.
to react to it,
Hmm.
which is why those types of treatments increase the tone.
Hmm.
There are time and a place to do those kinds of treatment, but we have to be choosy. And
Yes.
then I think when you walked into the class at CMC, what I was talking about was, how do you control pain with it?
Sure.
Right.
That's my general memory. Yeah.
Yeah. So there's two big mechanisms in the central nervous system, and they often call, one is neuromodulation, and then the other one's referred to as descending modulation.
Yeah.
And neuromodulation is like basic gate theory stuff. You
Yeah.
provide a non-noxious sensory input in order to block pain, usually at the posterior horn of the basal ganglia, blah 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 blah.
Yeah.
You know, that
Yeah.
that that whole
Maybe.
thing, right? So it's gate theory.
Yeah.
Descending modulation is you provide a noxious sensory input,
Yeah.
which creates the expression of neurotransmitters in the tissue
Yes.
that are, you actually express endogenous opioids and
Yeah.
endocannabinoids.
Yeah.
So
It's the
basically, what you're
endorphins
doing
and
is,
encapsulins.
yeah, you're making the tissue stoned, so it
Yeah.
cannot produce the pain messaging that goes to the brain.
Hmm. Hmm.
So I often say, why does Rolfing work really well for some people? Because most people understand that Rolfing is a fairly aggressive, very noxious kind of treatment for the most part.
Yeah.
It can be done nicely, but it usually is not.
Yes.
And then how does cranial sacral therapy or lymphatic drainage
Sure.
stop pain? Well, it's because you're kind of leaning on these two mechanisms that
Mm.
are really just theories, really, of how we can control pain in the body.
Yeah.
And as a therapist, you need to understand that you can use light touch, non-noxious,
Mhm.
but if your client's not responding to that, you have another tool,
Yeah.
which would be
Yeah.
the noxious. And
Yeah.
I'm not talking about taking them all the way to a 9 and 10 or 8
Yeah.
or 10 out of 10 pain, right? All I want to do is just get them over that 4.
Sure.
And then their body is starting to go,
Mm.
oh, this is scary. Let's adapt to it.
So I think the term that so if I in my head when I hear noxious, it's almost like you're really talking. And when you talk about the 4 out of 10 and the 5 out of 10, obviously being subjective, and it's hard for any individual as a practitioner to just like, I don't know, I think this is a 4, but this person thinks it's a 20,
Right.
right? So it's
Yeah.
it's that kind of ability through experience to figure that out. But that concept of 4 and 5 out of 10, and that concept of noxious versus non-noxious, and the concept of lighter touch being generally non-noxious and more abrupt or higher frequency or firmer, maybe we could talk about the concept of valence. So a positive or a negative direction, right? So
Okay.
the reason that I bring that up is because it lines up. I don't know if you have come across the theory of constructed emotion by chance.
No.
Okay, so if I would suggest to anybody who's in hands-on therapeutics that that is probably the most up-to-date approach to how sensations get turned into cognition, and then our output would be emotion, but
Okay.
essentially the brain's job is not to think, the brain's job is to manage metabolism, is the central concept, right? So you have sensory surfaces, you receive sensory information, you're going to generally, when it's novel, have no idea how to interpret it, but you'll look for something that's similar in the past, and then you'll interpret it and you'll put a word to it, right? So emotions aren't obligate phenomenon, they're categorical words,
Okay.
right? And usually the things that in term we would consider more negatively valenced will be more noxious stimuli associated,
Sure.
right? And then things that would be more positively valenced or more pleasurable will be generally more positive categories, right? Now, that said, you talk about exercise, the obligate sensation of exercise, especially when you're getting closer to the end of something difficult, is negatively valenced. It is not enjoyable, right? When you're getting into those more difficult things and those more strenuous things.
Yeah.
However, some people will take a positive interpretation of it. So I heard somebody say this, and I thought it was a really good. I think it was Chris Williamson. I don't know if you know who Chris Williamson is. He's a gentleman from England. He has the Modern Wisdom podcast. Very interesting guy doing great work. He was
Okay.
talking generally, and I think he was quoting somebody else. You do a really, really difficult CrossFit workout. You're on the ground, you're sweating, your heart is racing, you're breathing exceptionally hard. You cannot peel yourself off the ground. But you feel a major sense of elation at accomplishment, right? Now, that
Yeah.
exact same description, you're sweating profusely, your heart is racing, you're breathing uncontrollably, and you're driving your car by yourself down the street. You're calling an ambulance,
Yes.
but the same physical sensations are there. So
Right.
then what we can do is we can start to get to this place where we understand that a negatively valenced sensation can be positively interpreted,
Okay. Yeah.
and then vice versa, or a negatively valenced sensation can be negatively interpreted. But in at least what I would put forward in the therapeutic situation is a negatively valenced sensation can be very positively interpreted. Many people say, I want really deep pressure, I want it hard, I want it painful, right?
Yeah.
Like that is a phenomenon.
It
But I
is.
think what you're doing, as far as I can tell, is you're saying, and I like it because it's essentially you've tried it this way and it didn't do it, go that way,
Yeah.
right? Don't whoop them, but turn up the heat a little bit and see what the response is.
That's
Because
right.
it's an experimental protocol, right? You're like, the person is telling me this thing. I tried it this way. It should have worked. It didn't work. I have another tool or another direction. Say, same tool. I can use the exact same cup and just one more pump.
Yep.
And that's fair as far as as monitoring that boundary between non-noxious and noxious.
Well, so that's just the communication with the client,
Sure.
because it's their noxious that I'm interested in.
Absolutely.
It's not
Absolutely.
mine. I don't
No, no.
I don't,
I
and then
can't
you
feel it.
can't apply, like, I always laugh. My wife and I have a completely different physiology, it seems. Put a
Sure.
cup on me, I bruise instantly. You could leave one on her for half an hour, she might get red,
Yeah.
right? So, um, like, what we consider noxious versus non-noxious are two completely different things,
Yes. Yes.
right?
Yes. Yes. Yes.
So,
Yes.
and that experience, because we're so different,
Mhm.
really reinforces to me as an instructor that we have to teach our therapists that as much as we're the expert in soft tissue work, as much
Mhm.
as we're the expert in assessment,
Mhm.
hopefully, and figuring out the best way to treat this person,
Mhm.
rather than saying use light pressure, medium pressure, heavy pressure, do
Mhm.
it this long, look at how the patient is responding by visual inspection, by
Yep.
listening to what they're
Yep.
saying, but also by asking questions.
Yep.
And then instead of thinking about a technique does this,
Yep.
think about how the technique is experienced by the client.
Sure.
And that way you take that experience
Mhm.
to create the change,
Yes. Yeah. Yeah.
because it's noxious versus non
Mhm.
noxious in terms of application.
Mhm.
So if it's non-noxious, it's probably, if cupping, it's going to probably be lighter suction.
Mhm.
You're going to leave the cups in place or move it really slowly.
Yep.
You're going to use a lot of lotion so it's comfortable. You're
Uh-huh.
going to um, apply the cups even in a measured input. So you put it on lightly, then you, as the person adapts, you can increase the suction if you want,
Yeah.
as long as you're staying within that 0 to 4, if you like,
Yeah.
that
Yeah.
non-noxious, the patient feels safe.
Mhm.
And you can be assured that no matter if you use the technique of flash cupping, fast cupping, blanket cupping, massage cupping, or
Mhm.
cupping with movement, or
Yeah.
cupping for lymphatics,
Yeah.
you're going to get the same overall effect.
Yeah.
And then you choose the techniques that you like that
Mhm.
will meet other criteria within the outcome that you're looking
Yeah.
for.
Well,
So, if you're teaching someone to talk about noxious versus non-noxious, you
mhm.
have to teach them about how they're going to talk to their client, how they're
Yeah.
going to listen for
Yeah.
that variation.
Mhm.
And then really the application of cupping becomes easy.
Yeah.
And so same thing with soft tissue if you just remove the cups and use your hands.
Well, what you're doing is you're putting forth a framework to make choices.
Yeah.
So as you're noting, you're paying attention to the patient's response. Now, there's the visual that the practitioner could see, so you call that a sign. There's the auditory that the practitioner can hear, and you call that a sign. Depending on exactly how they're working, they could have a hand monitoring
Yeah.
and how that tissue is responding. Again, it's a sign.
Mm-hmm.
Anything the patient communicates to you purposefully would be a symptom.
Yes.
Right? So you've got a framework for choosing. You're like, okay, they say that it feels gentle, but they're squirming.
Yes.
I need to back off,
Yeah.
right? So you've got different choice points and monitoring points. So within osteopathy as a profession, generally speaking, one of the highlights is the monitoring hand. So whatever you're working on, you should ideally be touching it. Now, that's not actually consistent and chronic in all methodologies. So what you're doing though is you're centrally looking for the tissue to have some tension added to it with no negative responses, or the tissue to soften with generally softening responses. So you can't say positive or negative, but you're like, well, they said ouch, so I can't reef on this. I got to be gentle. But the central thing that I think is very positive in my experience is that osteopathic manual therapy says I have to pay attention to how they're responding no matter what.
No matter what. Yes.
But now it seems like in other professions, maybe how the methodologies are applied, maybe more procedural, and it's a little bit more like I do this, like this is what I do, and then how the patient responds, whatever. You can talk about HVLA, like high velocity, low amplitude. The whole concept is you're trying to go fast enough that they can't protect themselves,
Yes.
right? So they can't respond. And I'm like, well, that seems dangerous. So maybe not. Maybe that's why it's a protected act in Ontario. It's kind of illegal if you're not a specific
Yeah.
license holder.
Yeah.
Um, the but you've got a framework whereby these are the outcomes, right? This is how you know if it's this, and this is how you know if it's that. So the way that you know it's non-noxious is they're giving you no report, right? They're not squirming, they're not pulling away, the tissue's not twitching. The way that you know it's noxious is they start
Yes.
to give you some response. So in that, you've got a good framework. So if I take it to kind of my education
Yeah.
brain, you're developing good categories, right? So you've got two categories, and then there's ways to connect them because you have details to fill that in. So you could talk about a scaffolding, or you could talk about a semantic network or a network of related meaning. So in essence, you have a binary, and you've put forth already a binary choice, more or less. I would now if the binary choice is noxious or non-noxious. Now, if I was to generally make an assumption as to how you would roll this out to novices with
Hmm.
this concept, is you would probably say go non-noxious first as your starting point because you just don't know how they're going to respond. So you can relate that to
Exactly.
dose response. And then if it works, cool, don't worry. If it doesn't work, now you know how to get to noxious because you're just kind of increasing
Yeah.
these parameters until they give you a little bit of feedback.
That's right.
Yeah. Okay. So, whereas at this point for you, you probably have an internal framework whereby you're assessing and you don't necessarily go non-noxious first, depending on circumstance. You might like, no, non-noxious is useless for this. I'm going over here to start.
Yeah. I mean, so client comes in, this is an easy one. Like client comes in, has pain, and I say to them, my first time with a client,
Mhm.
and I say to them, have you had massage before? And they say, yes. I say, okay, what works for you?
Yeah.
Well, when I get this really deep from these couple of practitioners, it worked better than the soft.
There you go. Yeah.
Uh, I am not going to start with non-noxious.
Yeah.
Like
Fair
that,
enough.
I'm lazy as a therapist. I will be the first to admit I over assess
Yeah.
because I don't want to do things I don't need to do within my practice.
Sure.
So I assess, and that's my assessment for how much pressure or how much noxious or non-noxious I'm going to use. So that in and of itself tells me
Yeah.
the category that I'm going to start with,
Yeah.
and then I assess to see what um, what mobilizations I need to use,
Yeah.
what tissues affected,
Sure.
like what the tissue texture and the
Mhm.
tenderness is, et cetera, et cetera.
Mhm.
So like there's a lot more assessment that obviously goes
Absolutely.
into it,
Yeah.
right? But if I'm going to choose a category, that patient just telling me that is
Mhm.
going to save me
Yeah.
the start to then get
Yeah.
to noxious because
Yeah.
that's not going to work for them.
Yeah. Yeah. Yeah.
So
The thing that I would say, and I'm in agreement. Like I know exactly
yeah,
what you're talking about. The thing
yeah,
that I would say is that patient report is always interesting,
yes,
right? Not because there's malice or because there's an attempt to undermine or withhold information, but because you ask for preferences. Now, at least the way you ask, you're asking about outcomes, right?
yes.
Because if you ask about preference, if you ask somebody, do you like firm pressure or soft pressure? They'll tell you what they think they like. They won't tell you anything about the outcome. And this is
Correct.
where this is a decent anecdote. Learning styles. Like I'm a visual learner, I'm an
Oh,
auditory learner,
yes.
whatever, right?
Yeah.
The way that they figured that out as far as research was concerned is they walked up to people or they collected people and they asked them, how do you like to learn?
Oh,
That's the question. There was no outcome performance data associated with it. Do you
makes
remember
sense.
this? Do you remember the episode of The Simpsons where Homer said, like, I'm a male aged 18 to 36. Everybody values my opinion. And he pops open the cupboard and it's a can. It's nuts and gum together at last.
Right.
Sometimes what you're asking is for opinion as opposed to outcome. And
For
you're at least
sure.
asking for outcome. You're like, what works better for you? What's the better outcome?
Yeah, and that's really because my whole thought process is outcome based. Like
Yes.
I go into it, I go into every massage and I say, okay, what do you want to get out of this?
Yep.
Like, do you want range of motion change? Do you want pain control? Do you just want to lay there and let me rub oil on you? Like, because that is a valid outcome,
Absolutely. It
right?
is. Yeah.
If my patient is overstimulated in every aspect of their life, including their home life,
Yeah.
sometimes they just want no sound,
Yep.
no light, and
Hmm.
just have a professional touch them for an hour.
Yep.
And great, I can
Yes.
do that.
Absolutely. Yeah.
Right? Shut up, Paul. But others are very much, I have a pain right here, and I would be really happy
Mhm.
if it was not here when we're done. Okay,
Sure.
now I know what my outcome is. So
Yeah.
now let's work towards it.
Okay.
And that's that. I don't know that everyone does that. I think I'm a weird one
Sure.
because I do that.
Sure. Well, it's interesting because I think broadly, despite, say, even in your own experience, the amount of practitioners that you come across, you've got a company that's supplying practitioners tools, right? You
Yeah.
also have an educational business. You're at many conferences. You're interacting with people. You're getting information. You're getting feedback, and you're kind of taking your framework and listening to what they're saying and comparing. And you're also looking at the reactions when you teach them. They're like, wow, never thought of that. Right.
Yes.
So it's tough because maybe they do, but maybe they can't express it. So
Well, absolutely.
one of the hallmarks of expertise is can do, can't explain. Right.
Yeah.
So what I think I'm getting is you have kind of multiple buckets of systematized approaches that you've built over time, but you were able to build them because you said outcome, outcome, outcome.
Yeah.
Right? So you had the goal in mind, and then you built towards that through a skill set that grew over time and experience that filled those buckets a little bit more because there might be a move that you use in bucket A that you wouldn't think to use in bucket B, but eventually you're like, put it over here and see what happens.
Oh, for sure.
Yeah, yeah, yeah. So
For
it's
sure.
it's just it's building not only a framework that you can communicate, but it's showing that arc towards expertise that you can explain. And I would say it's highly likely you can explain it because for whatever it was that got you into teaching, that's the thing that turned it over where you had to create something.
Yes.
Yeah. When did you get into teaching? Did you ever teach at the college level or have you just been
I
doing seminars?
I did. I taught at the college level. I started as a TA with them. I taught at TA at Massage College, and
Mhm.
I was an instructor at
Okay.
the acupuncture college.
Okay. So
So I understand how the difference between foundational learning and
mhm.
continuing education learning.
Yeah, yeah, yeah. Well, it's so this is where me and my credential makes me go, oh. So learning is learning, right?
Oh, for sure.
You've heard of adult learning theory?
Yes,
My thesis supervisor wants to kick that out. Just
I
would like that doesn't exist.
I would
She's a cognitive
I would
psych,
agree
but
with that.
yeah, she's a cognitive psych by training. It's learning is learning. The fundamental mechanism, the description of it is stable. A lack of information to now having information, but it's got to have some change in behavior that can be identified,
Yeah,
right? Now, the other thing is you have to know it's what is that's that stupid four square, like
yeah. You have to, yeah,
conscious incompetence,
conscious. Yeah, yeah,
yeah,
yeah,
all that, whatever. It's an okay description, but
yeah,
the people that usually talk about it, they talk about it with a little, with a little unjustified confidence,
yeah,
right? Or unjustified level of certainty. But basically, the idea is if you don't know you don't know something, there's nothing to learn. But if
yeah,
you know that you made an error, you can learn because you know the outcome goal, right? So you have to have a target, and once you know the target's there, you're going to start adjusting anyways. You don't need too much feedback, but sometimes there's some feedback that's required because you just have no idea how to get closer to the target,
right.
right? But the other thing is that you can make the initial thought that when somebody has graduated, that they're at least a competent novice. So there's some stuff that you don't necessarily have to go over. What I will say, in my experience, is I don't assume that anybody knows anything. So I can then be accused of being wordy in my explanations. It's like, listen, I looked at the room, I said something really straightforward, and some people looked at me like I shot their dog.
Yes,
I'm fixing this now.
I get that a lot.
Yes. So
Yeah,
that's where I'm like, okay, I don't. So I like what you're saying, but because I didn't know that you TA'd and at both massage and at TCM. Would it have been a TCM school? Because did you do
it
that?
was yeah, it was a
Okay.
TCM school. So I'm fully like
Yes.
Chinese medicine practitioner. Yeah,
Now you did massage in Saskatchewan,
in Manitoba.
Manitoba. Okay. See, this
Yeah,
is why I ask, because I'm like,
I appreciate it. Yeah.
and then did you also do TCM in Manitoba?
Yeah. So
Awesome.
I did my phys ed degree in Manitoba. So
Nice.
like it's I had that university experience,
Hmm.
then I had the small college
Yep.
experience, then I had the really tiny college
Yes.
experience. There
Yeah.
were like my graduating class in TCM school, it was me.
Nice.
Yeah.
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 Well, you're dedicated.
Well, so I actually like I took it over as part-time and I took it over a good chunk of time. And so I had people that started with me that never finished. I had people that I picked up from other years
Yep.
that were going slower and I
Yep.
passed them. And then I had a group of students who started, but they started really frequently. So they
Uh-huh.
caught up to me.
Yeah.
And but I was more prepared at the exam time than they were.
Yeah.
So I wrote the exam and graduated, and they took another semester.
Yeah.
But yeah, it's just it was a really flexible school
Yes.
environment. It's fabulous.
Okay. That's awesome.
Um,
But
and then I practiced for a couple of years, and then she asked me to come back
mm,
to teach some of the
oh,
courses.
yeah.
Yeah,
Awesome. And that's the thing. You really early on, you had the opportunity to translate your behavior into a communicated thing,
yeah,
right? So you have to communicate with words and actions and then be able to correct actions. So that probably by sheer requirement helped you build what I would describe as a systematized approach.
for sure,
Yeah,
absolutely,
nice.
absolutely.
That's
And
awesome.
the talking about it as noxious versus
Hmm.
non-noxious, that's been a product of probably the last 2 years, maybe
Yep.
three.
Okay.
I used to mention it in passing when we talked about pain control in
Hmm.
cupping, but I really, at some point, it became how I talk about you can do this technique, but you're probably going to do it this way. And
Yes.
noxious versus non-noxious
Yeah. Yeah.
became the placeholder
Uh-huh.
words
Yeah.
for all of the concepts of how you do the techniques.
Yeah. 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 What's the
And it's
it's
just
it's
easy
the
way to,
application choice,
yeah,
right? So like it doesn't. I could put the cup on like Jimi Hendrix like this,
yeah,
like playing the guitar upside down and backwards.
right.
But the idea is that I'm monitoring for no response or some response.
Yeah.
So it's the behavioral choice.
Yeah. And so the really interesting, so it just occurred to me, you're actually not monitoring for no response
Hmm.
because in a non-noxious
Hmm.
sensory input, as you put the cup on, at that point, there should be no response
Yeah.
or little response.
Yes.
But often what they'll say is, oh, that feels nice.
Okay. Yeah. Yeah. Yeah.
Or they'll say, you put the cup on and you're either manipulating it or not, just depending on which
Yep.
technique you're choosing.
Yep.
And after an amount of time,
Uh-huh.
you watch for the adaptation
Uh-huh.
to the intervention, which
Hmm.
would tend to be them telling you that it feels better. Oh, I just felt that muscle release. Or they'll do the big,
Yeah. 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 Okay.
or they'll wiggle a little bit as
Yeah.
they try and extend their spine as they're laying prone on the table
Yeah.
or whatever. Like you're watching for a response to the adaptation,
Yeah.
but you don't want a response necessarily that is negative
Yes.
to the application.
Yeah. 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 Well, and the reason I say no response versus some response is
Yeah.
just because of how I'm classifying in my head as we're having the conversation. So
Yeah,
the
absolutely.
clarification is useful because it's like, so if you're going non-noxious, as you engage, you really shouldn't see too much aside from maybe, oh, that feels nice.
Yeah.
So something, some form of positive response. Whereas if you're going noxious, you would suspect that you would likely at engagement see some form of visual or auditory response where it's like it's beginning to be a little rough.
Yes.
Okay.
Yeah.
And then
And so what I often do is I say, okay, on based on your scale,
uh,
I don't want this to go above a 4, or I want it to
yeah,
go over 4, but not to 6.
yeah. Mhm.
So that's kind of the window I give myself,
Okay.
so that they don't have a, so I know if I'm going to be noxious, I could go all the way to 10
Yeah.
and get my outcome.
Yeah.
But I don't need to live there.
No.
Like that's not a comfortable thing.
Mhm.
So because in my one of the things I like to talk about is, does your treatment even matter?
Sure.
And so what I mean by that is your intervention on this client is an hour
Mhm.
in their 24-hour day.
Absolutely.
If you see them once a week, it's an hour in their however many hours are in a week.
Yeah.
It's like, one 306th or something like
Yeah.
that,
Yeah. Yeah.
whatever number that is. So it's this little period of time that is utterly meaningless,
Mhm.
but yet as one intervention, it doesn't really matter unless you get the outcomes they're looking for. But the whole thing is, when you think about therapy, or manual therapy in particular, we know from dosage studies that the more often it's applied, the better the outcome is going to be. So my point of this is, if I'm operating from 4 to 6 out of 10,
Mhm.
it's uncomfortable, but it's not terrible.
Yeah.
But if I'm 7, 8, 9, 10 out of 10 noxious, the client's not coming back to me. So
Yes.
is my therapy useful?
Yes. 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 Yes.
Well, in general, probably not.
Sure. So maybe
Probably
let's
not, even
say,
if I got them to their outcome.
yeah, so you go 10 out of 10 and the you get the pain to change, you get the movement improved. But because it was such a negative experience, you've limited the ability for it to happen again should it need to. Yeah.
Correct.
Yeah. So it's basically like, don't be a jerk. And maybe they'll talk to you again.
Right.
Right. Sure.
Don't laugh at them while you're applying this kind of thing.
Well, I would say when they are providing feedback that is negative, like this is bad, don't laugh at them then.
Right.
Now, I am known to laugh at almost everything, right? I've had discussions with my daughter about that. Like she's like,
Yeah.
Dad, I don't like it when you laugh at that. I'm like, I appreciate that you're telling me that. However, I laugh at almost everything. So it's a central part of my personality, but thank you. I'll do
Yeah.
my best.
Yeah. Yeah.
But
But it allows you to modify your behavior as well, right? Because
yeah,
there's been communication.
yes. Now, the challenge being that it's like laughter with malice or laughter without malice, right?
I like to think of it as laughter with the client,
Yes.
or
At
at the client.
yes. Yeah, 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 absolutely. So if somebody comes in and they're not doing particularly well, right? There
Yeah.
is there's there's a way in which laughter can share the pathos,
Yes.
right? And
Oh,
I
for sure.
I do that a lot. Now, it actually relates back well to the theory of constructed emotion because the concept of laughter, most people would think laughter is, you're laughing in a particular way and they would interpret it a particular way depending on the culture, right? So for me, laughter is almost everything because sometimes laughter for me would actually be described as pathos. It's not described as humor, it's
Yeah.
pathos.
Right.
Right? Whereas, say, a scowl in most cultures that we're aware of or that we would connect with, a scowl essentially means somebody's closer to or angry. However, if people have a scowl on their face, you observe a scowl and you ask them what's going on, it's about 30% of the time they're angry, 70% of the time there's something else.
Yes.
Right. So it's like, okay, the what you see presented does not necessarily match what you interpret.
Oh, for sure.
Yeah. So yeah, but yes, don't take obvious negative delight in the pain of
Of
somebody
others.
else.
Yes.
Yeah, maybe we need to do some other stuff with you if that's the case.
Well, yeah, and so and like that whole and that communication with the client, whether it's laughter, I mean, I'm the king of dad jokes in my clinic. There is, my favorite one as an acupuncturist is, "Oh, your pain's God? That means I did a jab well done."
Yes.
And like
Yeah, well done.
it's just the dumbest thing,
Yeah.
and I get a laugh out of it nearly every time, as long as I don't say it to the same person over and over and over again, right?
Yeah.
Um,
Get a new
but
joke.
but yeah, absolutely, you got to change them up. But the providing the context around treatment is important too,
Mhm.
right?
Yep.
So um, when I'm talking about to a patient about what I'm going to do and how I'm going to do it, and I'll talk about a pain scale because it's easier to understand than noxious versus non-noxious.
Mhm.
And so when we start talking about that pain scale, I usually talk about their responses. So I often say, well, at 4 and 5 out of 10, you're going to have an eye twitch.
Yeah.
You're going to start wincing a bit. You will probably not even notice, but your muscles in your body, wherever we're working, are going to start to tighten, and I'll
Yep.
see that before you will.
Yeah. Yeah. Nice.
And then at 6 out of 10, you're going to start pulling away from me,
Yep.
right? So if you've started pulling away, we're already at 6.
Mhm.
That's as far as we need to go to get the response out of your body that I
Yeah.
need
Yeah.
to get
Yeah.
to, again, drawing it back to their outcome, to increase the strength of this muscle so we can
Mhm.
increase your range of motion or to decrease your pain level.
Yep.
So once we're there,
Yeah.
that's it. We're
Yeah. Yeah.
done.
Yep.
So don't let me continue
Yes.
ramping up the pain because this is not a case where more is better.
Yep.
So I've said all of those things before we engage in that
Yep.
so that they have context. So that context allows me to do a noxious stimulation, yet maintain the overall safety
Yes.
for my
Absolutely.
patient.
Yeah. Yeah.
And that is a really, I think, important thing within the therapeutic context is they have to know when is it too much because it's their
Yes.
experience. I can't tell them that. And
Yep.
I can guess because I've got 27 years of practical
Yeah.
experience. But if there has been a muscular or tissue injury there, I have no idea,
Yeah.
right?
For sure.
Like, it's really up to them to tell me.
Yeah. Yeah.
So just giving them those little uh high level watermarks.
Mhm.
This is a 4.
Mhm.
This is a 5.
Yep.
This is a 6.
Yep.
Let's not go above that.
Yes. Absolutely.
And that way they have control
Yes.
of the amount of noxious treatment that I'm giving them.
Yeah. So I think what I like about that is that what you're describing in for me and what I've seen across time is just the behavior of a good clinician. However, the term that would probably be popular right now is patient-centered care,
Sure,
right? And
absolutely.
but patient-centered care, I don't know if you remember the specific terms with respect to ethics, right? So non-maleficence, beneficence, autonomy, and justice,
Yeah,
those terms.
yeah,
If you read anything about those terms, patient-centered care is completely embedded in them. So I'm like, we should talk about ethics, right? Like
yeah,
first, don't do anything you know is going to hurt them,
right,
right? Second, do everything you can to do something that's going to be net beneficial to them. But built into both of those, they must be able to you tell them what's going to happen, and they should be able to make a choice. And if they say no, well, it's no, right?
correct.
Yeah. So it's like, well, okay, well, patient-centered care is in ethics, so whatever. But I appreciate that you do something similar to what I do. What I say though is not necessarily about noxious. It's basically like, listen, I can't feel what you feel because if I could, I'd be feeling too many feelings.
Yes,
What I'm going to monitor is these things. Now, if it's starting to get to a point, so I do a similar thing though. If it's starting to get to a point where you want to pull away, tell me,
Yeah,
because I want to back off before that point. That's my job. If I can't tell that you're getting to that point that you want to pull away, tell me so I can back off.
right.
Right. So you and I have come to a very similar communication strategy. It's just that you're willing to go a little bit more into that.
Yeah,
Like if they're pulling away, it's like, okay, we're stopping there. We're not going any farther. I say, if you want to start pulling away, I want to back off. Right. So
yeah,
generally different approaches, but similar communication strategy.
absolutely. But I also value that noxious stimulation for
Yes,
some of the outcomes
absolutely.
that it can create.
Yeah.
So, and as an acupuncturist, I stab people for a living.
I
Like,
know.
I mean, really, I said that to a US border guard once. He
Oh,
says, "Oh,
how
you're an
was
acupuncturist." I said, "Yeah, I get to stab people for a living." And he says, "Don't stab anyone in the United States." I said, "No problem." He says, "Have a nice day."
okay? I was like, how'd that go? Border guards don't have the best senses of humor.
He was hysterical. He was
Good.
having a great, like, you could, when I was standing in line, I'm
Yeah.
like, I want to go see that guy
Yeah.
just because I want to add to his entertainment. He was
Okay.
having a great time.
Good. Okay.
Yeah, he was yelling at the other border guards, like in play, like
Yeah.
in
Yeah.
jest. He was having a great time. I
Yeah.
totally loved that energy.
Thanks. Yeah. For me, I've had acupuncture, and I've had varying responses to it. But like this is where for me there was a gentleman. You don't know Toronto particularly well, is that fair?
I know a little bit of like the areas of Toronto,
Okay.
but I'm not.
Chinatown East is Broadview and
Yeah.
Gerrard.
Yep.
Did you ever go there for any reason?
Oh yeah.
Okay, do you know Dr. Chen? Chen's
No.
acupuncture and herbs?
I have actually been in there, but
Okay.
I don't know the doctor. I went in actually looking for some herbs one day.
Yeah. His wife would mostly be at the front. Now I literally have no idea if he's still alive, but it was his wife usually working the front, and he was treating. He spoke Mandarin, Cantonese, Korean, and English.
Wow.
Right? I've had I there was a lot of sprinters that would go see him, and bodybuilders too. So because I used to sprint, not good at it, but it's what I do. I, People told me I should go see him, so I would go see him. I had good results with him, and it didn't bother me that he was stabbing me.
Right.
However, almost anybody else with respect to acupuncture, because I've had other people attempt to practice acupuncture who were going through varying schooling processes, man, I don't like it. And
Yes.
in my head, it's mostly because somebody's stabbing me and I'm not allowed to fight.
Right.
I'm supposed to fight when this happens. Like I also had an interesting experience with needles when I was young,
Oh,
right?
okay.
It's
Sure.
it was an allergist, but it's the sensation of the needle is not terrible. Like it's the context, and I'm like,
Yes.
I'm supposed to fight you.
Yeah, but also if it's a student of acupuncture, like they're operating at below novice levels.
Sure, it this
So like versus someone who's practiced for 30, 40, 50 years. I
yes,
mean,
yeah,
I myself, like most people don't know that I've put the needle in. Like I've done it
fair
enough
enough.
times and I
Yeah,
use such a high quality needle
yeah, yeah,
that it's in and you're like, oh,
yeah. Yeah, so that's the thing. I haven't, because of that concept in my head, I haven't had a broad enough experience, nor
yeah,
have I had the perceived need to look for it,
yeah,
right? But I appreciate that because that helps me with my idea, and
yeah, yeah.
it opens up my questioning for other people because yes, the person that was the novice, or the primary person that was the novice, uh, I had reason to trust them generally, but it's like when stabbing me, maybe not.
Well, and then there's also the relationships, right?
Yeah.
So you going to see Dr. Chen, you're going to
Mhm.
see a professional that you were referred
Absolutely.
to.
Yeah.
So not only is he a professional, but he was also referred. So
Yeah.
his standing already,
Yeah.
and you're going for acupuncture.
Yeah.
Now
Well, it's
your
also the
buddy that's practicing,
yeah.
first of all, you have a completely different relationship to
Yes.
start off at the beginning.
Yeah.
So, and they're a student, so you
Mhm.
don't trust them
Yeah.
completely. You remember what you were like when you were a student, and like
Yeah.
all of that, right? There,
Sure.
it's so much context.
Sure. Well, to be fair, the stimulation or the sensation when that person put the needles in wasn't bad at all. They did a really good job. Like I know
Yeah,
they did a good job. It was the thinking beforehand, and I
absolutely.
think it relates relatively well to everything you put forth there. So yeah, the now just with respect to noxious and non-noxious stimuli, as far as you can tell, are you at least with those terms, are you really the only person that you're aware of saying it that way?
Not really.
Okay,
So there, Diane Jacobs,
okay,
she was a PT in Saskatchewan. She just retired a few years ago.
okay,
She always talked about her whole 30-year claim to fame of a continuing education practitioner. She used to call her practice dermo neuromodulation.
okay,
And her whole point was we should never do anything that's noxious. It all
okay,
has to be non-noxious.
okay.
And while I appreciate that approach, I don't agree with it
Sure.
wholeheartedly.
Yeah,
But if you read it, when her website was still up, it was all talking, no matter what techniques, it was all noxious versus non-noxious.
okay.
And certainly when I've spoken to people who've taken courses from her, I never got a chance. I didn't find her until she'd already stopped training other people.
Okay.
Um, she was very much a practitioner who thought in terms of that, and her students definitely
Okay.
use that kind of wording.
Sure.
Do I know anybody else who does? Not really.
Okay.
Not in those terms, and not in the
Sure.
maybe the application of it.
Sure. Well, I heard Scott Dartnell talking about it was just a simple conversation I was having him, and one of the things he said, and he was talking about massage therapy education, and he was saying to tolerance and no more, right?
Yeah,
So I think he was talking about general, say, feedback from the patient as far as pain tolerance and no more. So is
yes.
that a term, kind of a terminological thing you've come across?
um I hear people talk about to tolerance. I've
Yeah.
never heard anyone tack on the and no more.
Okay. Okay.
But
Well,
that,
Scott did, so
yeah,
there you
well,
go.
he's got a he's got a good brain in there.
Yeah, he does.
He does.
But he likes to have fun.
Oh, absolutely.
So,
Absolutely.
and I bring that up just because from somebody who's been involved in continuing education, massage therapy education for a long time, he provided me with terminology that I thought I observed but never heard.
Yeah.
And you saying noxious and non-noxious, and noting that kind of through that Diane Jacobs sphere that so it's like the phenomenon is always there, and the phenomenon is definitely there with an osteopathy with the barrier concept. Like the phenomenon is there. It's
Yeah.
just maybe the way that people are talking about it is variable. And I appreciate it. And that's why I want, because you piqued my interest with just those two words. I was like, huh? Like, what's that?
I actually saw it happen because you came in and you were standing on the side there, and I was lecturing. And whenever people like who are like coming and going, the like all of the staff at CMC and a lot of the instructors, if they're not busy, they'll step into other people's courses
Yeah.
just to kind of you learn something every time, right?
Yeah. Yeah.
So I was talking and you came in. I think I actually even said hi to you
You
during
did. Yeah.
my conversation. And then I continued on saying what I was doing. And then I saw that look in your face like, oh, that's interesting. And then I saw the wheels move. And then
Yeah.
I went back to the other side of the room. And then I looked back and you had left the room at that point.
Yeah.
I'm like, oh, I bet you I know what he's thinking about.
Yeah. Well, it's so the thing that I like is that the phenomenon is the same, the discussion is variable. So to have discussions of this nature, to bring like, okay, it's this perspective, this word, this word. Oh, wait a minute. Okay, okay. So we can start to do something. But the way that I appreciate that you're approaching it is that you've got a decision point and monitoring points for application. I think that's exceptionally important. So for me, as I already said, like if I turn somebody into resistance and they say ouch, well, I don't do that.
Right.
Right. That so it's I can, but if I can turn them into resistance and there's no negative feedback, then I'm monitoring for tension to go up with no negative feedback.
Right.
Versus if there's negative feedback, I'm just trying to shut down all the tension.
Right.
right? I'm just trying to shut it down. So like it's like I can't, maybe if I accept the concept, or if I onboard the term noxious versus non-noxious, what I could say is that going into resistance without the negative response would be getting to your four,
Yeah.
right? So it's like we're doing the same thing, but the governing concept is a slightly different angle.
Yeah.
Yeah. So and I appreciate that, where it's like, oh well, we're different because of this. It's like, maybe you are, maybe you aren't, but because the substrate or the thing that we're working on is the same, it's another person,
Yeah.
and we're a person interacting with another person in some way in a goal directed fashion,
Yeah.
then all of a sudden it can start to come together. So the phenomenon is stable, the work is stable, the discussion is funny.
Yes.
Yeah, fair enough.
Always.
Okay.
Well, I always laugh. Like we talk about, especially when you talk people who have this, especially wonky ideas of Chinese medicine.
Okay.
They've brushed against the outer layers of Chinese medicine,
Mhm.
and they think they know stuff. And then they talk about Western physiology application, and they start sprinkling in
Mhm.
Chinese medicine ideas, which are patently wrong,
Sure.
right? But they think that they're doing the right thing. And I, I, I always say your story is wrong.
Yeah.
Your treatment,
Mhm.
perfectly acceptable.
Yeah.
But the story that you're telling
Yeah.
is wrong. And here are the logical fallacies that you're presenting your patient with.
Yeah.
And it's not necessarily because you got it wrong.
Mhm.
It's that you are trying to mix two metaphors or two stories, because
Mhm.
honestly, Western physiology is just our story of how we talk about the
Yeah.
body working, in
It's
much the same way as Chinese medicine physiology is their story. There's like old Greek medicine
humors.
flavors or
Humors. I
humors.
think it's
Thank you.
humors. Yeah. Yeah.
Like there's that, like that's a story about how the body worked, and
Yeah.
people use that for probably hundreds or if not thousands of years, right?
Yeah. Yeah.
So it's all of these are just ways of trying to explain how the body works.
Mhm.
So pick one
Yeah. Sure. And stick
and
with it.
stick with it,
Yeah. Yeah. Yeah.
and don't try and drag stuff in from other stories,
Yeah.
because that may not make sense.
Yeah, yeah. Well, what I think, and it just popped into my head now, the literally true or metaphorically true, literally false, the concept of a story, say physiology, or like the term physiology being an approximate description or an approximate story. So just the way that, because you have to check all these different people and see if it's kind of a stable phenomenon, and then you kind of throw the outliers out and you normalize the data. So it's almost that process, right? That process of observing many, throwing out the real outliers, getting close to the norm, kind of smoothed out data, and telling that story. If
Yeah.
people don't know that the other steps happened before, then they don't know what that story is. What I would say is that almost all of them probably go through that process, because TCM was, if the terminologically, if I remember this properly, TCM is the only medical system that's been fully developed in vivo, right, in
Yes.
living subjects, because there was no dissection traditionally in Chinese
Traditionally. Yeah.
culture.
Yeah.
Obviously, it would occur to some degree now, but traditionally, when Chinese medicine was developing, it didn't happen, so they couldn't look internal.
In certain times it
Yes.
was
Okay.
because Taoist medicine or Taoist philosophy really, and so did Buddhist philosophy, really frowned upon you taking apart people.
Yeah. Well, it's the ancestor type culture,
Right.
right? So they had a lot of data. They normalized it, and they tell the normalized story, and any practitioner will have to start to adjust. So an MD is going to use physiology as the basis, the normalized story. They've got reference ranges, and then it's like, okay, this is over here, so I gotta do this. So
Yeah.
what I would say is that, say, for internal processes, your MD probably just has a way more monitor targets to monitor,
I
compared
think
to other healthcare systems.
I don't know that that's necessarily true.
Sure.
I
That's
think,
fair.
yeah, I think that everyone has the same target. You just use a different logical
Sure.
framework to get there.
Well, I think what I'm saying is target monitoring targets. So where we're all looking for certain types of outcomes in a big sense, the MD can look at your hematocrit. The MD can look at your B12 status. The
Sure.
MD can, whereas the osteopathic practitioner, the hands-on osteopath, I got none of that. I'm on the outside. That's all I got.
Yeah.
I can it either the soft tissue either squishes or it doesn't, and the joint either moves or it doesn't. Like
Yeah.
that's what I got. Now I can make a lot of stories up about what's happening internally, and I can be very wrong, and I can accidentally be right. Whereas the ability to monitor
Yeah.
physiological markers means there's more markers to monitor.
Sure.
I think that's maybe the more
Yeah.
accurate way to say what I'm trying to say. But yeah,
Yeah.
like we'll have the same goal.
The outcomes though are always based on patient experience.
Yeah, well,
Do you have
yes, and
pain?
patient
Has your
experience
inflammation
is
come back? Do you have more energy? Do you
yeah,
have whatever?
yeah, and the patient experience uh, is related to internal sensory surface, right? So it's like,
Yeah.
of course, yeah, you do a massage, are you impacting physiology on some level? Yeah, you just don't know how,
Right.
right? You got a good guess, and you'll tell something, but yeah.
Yeah.
So I think the normal, so many data points, normalizing the data, kind of tell that central story, and just make sure everybody knows you're gonna have to go over here and over here, right? Like that's what you're going to have to do in actual practice. So yeah, okay. So what I will say for now is that does what I need to start to understand how similar their approaches are, even though the words are different.
Yeah.
So I'm going to wrap this discussion up for now. So
Sounds
I
good.
will, but I'm going to say goodbye to you properly when I stop recording.
Yeah.
But what I'll say now is thank you very much. That was really, really positive for me, and I appreciate the crossover. I really like that. So thank you.
And thank you, Sam. I love the opportunity to speak with you, recorded or not.
Yeah, yeah.
Um, so yeah, I look forward to the next time I see you at CMC. Are you going to be in, where are we going? Calgary?
Calgary. As far as I'm aware, I will be there.
Nice.
Primarily, though, I think I'll be there as the AV guy. I might have to wear all black.
Ooh, very
No,
nice.
it's just it's
It's
an
a
it's an
formal
AV joke.
occasion.
No, I just make fun of AV people because they're
Yeah.
always in all
You're
black and standing
always wearing all black. Yeah.
Yeah. No, so I believe as it stands, I will be there. If to support and if needed, I'm sure I can talk about stuff.
Yeah, maybe once.
Fair enough. Okay,
You'll
so
even maybe have an opinion.
yeah, but it'll be informed.
I should hope.
Yeah, okay. So I'm going to stop the recording now. There we go.